Good morning again, everyone. Now that we can see prostate cancer, diagnose it accurately, stick a needle in it, characterize it, and be sure that there's no cancer anywhere else in the prostate pretty well. Next horizon is to use an external energy source to ablate it, and that's what I'd like to address with you for a few minutes today and show you what some of the possibilities for the future may be. Just to review for a moment, focal therapy has been very successful in other organs, primarily the breast, but also kidney, thyroid, lung, and colon. I want to pay tribute to the man who really started all this, Bernard Fisher, a general surgeon in Pittsburgh, who devised a clinical trial that has now been followed out 20 years comparing women. This is a randomized clinical trial comparing women with breast cancer treated, and this is a selective group, just like our focal therapies will be. Women who qualified were treated either with lumpectomy or classical Halsted mastectomy, and some of them had radiation therapy in addition, but it didn't make a lot of difference. And the success rates were basically the same 20 years later. And the results of that trial stimulated others. Focal therapy of prostate cancer really started with Gary Onek, a radiologist, practices in Florida. In 2002, he published the first prostate focal therapy paper when he showed that he called it nerve sparing, and it was cryosurgery. Cryosurgery is the oldest form of focal therapy available. That's all he had in 2002. And in 2008, same author coined the term male lumpectomy, and that has fairly well stuck. When I describe focal therapy to a man and his wife is present, she gets it much quicker than he does. He made the statement, a very forward-looking statement back in 2008, male lumpectomy could have a profound effect on prostate cancer management, and indeed it has. I'm going to tell you the reasons that focal therapy is compelling to me. Our interest in this really started in 2012 when we invited Hash Ahmed to come in and give us a talk on focal therapy. He spent a week at UCLA. This is our group with him. If any single individual deserves the title of father of prostate focal therapy, it would be Dr. Ahmed. He practiced for years with Mark Emberton at UCL in London and now runs his own shop at the Imperial College in London. These are the reasons that I like focal therapy. We can now localize the disease using a combination of MRI and biopsy data. It's been quite successful in other cancers. Not 100%, nothing is, but it's been generally successful in many other cancers when both solid and hollow viscous are treated with this. It's been very successful. Think about if a man has lung cancer, you don't take out the lung, you take out the segment. If a colon cancer, you don't take out the whole colon, you take out the bad part. It should work well in prostate as well. The efficacy of whole gland therapy has been called into attention. The Pivot trial was shown earlier today. Freddie Hamdy's new work has been shown. There are other big, the Scandinavian trial, all showed the same thing, that the efficacy of whole gland therapy, especially for low risk and intermediate risk prostate cancer, is not what we thought it was. It's very interesting to me that Pat Walsh, one of my personal heroes, taught us how to do radical prostatectomy without bleeding out the patient. Most of his cases were done for Gleason 6 prostate cancer and wouldn't be done today. So the efficacy of the whole gland therapy has been called into question. The monoclonal index origin of prostate cancer is increasingly well established, says that there may be multifocal disease, but the mother lesion is what controls metastatic potential. If we take out that one, we have done the patient a service. Hash Ahmed published an article in 2009, which I highly recommend to you. It's a 2-page article in the New England Journal of Medicine proposing the index lesion of prostate cancer, and it's been increasingly well accepted since that time. And the other reason I like this is because I want to do what the patients want. And patient preference for limiting complications of treatment is so dramatic that the AUA has a main concern with focal therapy, and that there's a potential for abuse, that it may be used inappropriately just to make the patient happy. And this has to be considered, but patient preference is very strong to avoid complications. There is a nice article from Ahmed's group in London showing that men will trade years of length of life for years of quality of life. It's a very important factor. So focal therapy has, as I said, been around now. We're about 20 years into this. Still pretty new. The oldest form of focal therapy treatment is cryotherapy. It's done in an operating room. It's done transperineally. Urologists do this. It requires general anesthesia. Generally, there are some people moving toward local anesthesia, but I don't think very many. It's not well accepted yet. Typically, larger portions of the prostate are excised are treated then by other areas. Medicare pays for it. HIFU was approved by the U.S. Food and Drug Administration in 2015. It's done in an operating room. It's done with a transrectal ultrasound probe that both images and treats. It's done by a urologist. It requires deep, general, paralytic endotracheal anesthesia. Even a little movement will throw off the co-registration, which is important because this is extremely precise. Medicare now has expanded their program and does cover HIFU, but many private carriers do not yet. They will with time. Laser therapy is another option, currently done primarily by radiologists, but will be increasingly done by urologists, I believe, in the future. It is done in the clinic, can be done transperineally or transrectally. It requires only local and sedation. It's very precise, and nobody pays for this yet except for the patient out of pocket. And the other method of focal therapy is irreversible electroporation. I have no personal experience with it. We're beginning to do some at UCLA now. Dr. Brisbane will make that his mission. It's done transperineally in an operating room under anesthesia. Urologists and some radiologists are doing this. Again, requires deep general anesthesia. It's precise, and Medicare pays for this one as well. So these are the 4 methods of focal therapy which are currently available to men in the United States. The guidelines have been published on this by the NCCN, AUA, and EAU. All of them recommend that these treatments be performed in clinical trials if possible, and if not, at least with very good follow-up. And the patient must be led to understand how new these treatments really are. I mentioned earlier, and others have shown this also, when MRI is used for planning focal therapy, it can't be used alone. It may be the cornerstone and may take us to the area that needs to be treated the most, but it certainly does a poor job by itself of defining the extent of prostate cancer. In these 3 examples, the MRI visible lesion is shown in green, and the actual tumor on whole mount prostatectomy is shown in red. And in each case, there is a fairly extensive, irregular, and unpredictable extent of the cancer beyond what the MRI shows. What the MRI does really is show where the cancer in the prostate is most likely to be. And that's all. So we must have a supplement to what the MRI shows in terms of predicting margins for treating focal therapy. Alan Priester, who got a PhD degree based on MRI and whole mount correlations, is a biomedical engineer, and he showed in his paper here, good paper for you to look at if you get a chance. If you compare the actual volume of the prostate cancer seen on MRI versus that seen in the actual whole mount specimen, there's about a 3-fold difference in typical patient's volume of prostate cancer. So remember this flaw in the MRI. It's a frailty, an underestimation of prostate cancer extent, which is quite predictable. So how to deal with this underestimation of prostate cancer margins if we want to do effective focal therapy? Well, in his paper, Priester showed that if you take biopsy sites around the ROI, that you will be able to get information that will help you in focal therapy. To compensate for MRI underestimation, additional core could be taken around each visible MRI. And that's what we have done to try to make this all more accurate in terms of predicting. Again, to reemphasize what I talked about this morning, the value of tracking biopsy, which we talked about some years ago, is increasingly apparent in men who are candidates for focal therapy. This is an example case where we've used focal therapy used biopsy tracking to come back to a lesion, sample it again, and determine its progression rate in active surveillance, but it can also be used tracking to determine where the positive and negative biopsy cores are. In other words, how much you have to treat to do a good job doing focal therapy. This is a little video clip that I showed earlier today. The white spots all represent tracked biopsy site locations. And what we have, and the software, what it does is allow you to subtract out the negative biopsy sites, which the operator is doing right here, leaving only the positive biopsy sites that we want to go back to and focus on. And if this were a targetable lesion that we were going to treat with focal therapy, we would have those tracked spots to help us determine how to approach this lesion. Again, the umbra and the penumbra become increasingly important as we talk about focal therapy. This is a case where we use that technology, the engineers, to measure these distances between positive and negative prostate cancer cores, and helped us to predict just how far out we need to go with our biopsies. So not only would we initially do systematic or templated biopsies throughout the prostate to complement the targeted biopsies, but in going back, we have to think about biopsy as a part of the planning method for treating focal therapy. And if we were to go back and do a planning biopsy, we would include lots of penumbra biopsies in this patient that'll help us plan and treat effectively. The umbra and the penumbra. So let me just show how this works in actual practice. You know, people doing focal therapy nowadays are either doing hemigland ablations or drawing a concentric circle around the lesion, hoping that they will encompass it if they make that circle around the lesion large enough. This shows the chances of incorporating clinically significant prostate cancer versus the distance from the region of interest. And I'm going to overlay an example cancer to show that if you were to use a concentric circle, let's say you thought a centimeter was enough to go around this cancer to encompass all of the cancer, you would have to draw a very big circle to get all of that cancer because of the irregular and unpredictable nature of the way these cancers grow. They don't grow like a ball. They grow frequently in fingers. So this is a good example of how we have to do this. So when we're sampling a patient for trying to determine how to approach this focally, we not only want to sample the umbra, but we also want to sample the penumbra, and that will help us know how wide to make these margins. So I mentioned earlier, we've done a lot of these targeted biopsies all the same way with both systematic and targeted biopsies. We have done an average of about 15 cores per session. Each biopsy core, it turns out, is a trove of valuable information, including not just the Gleason score, primary Gleason score, secondary Gleason score, cancer core links, the also spatial correlations, both within the prostate and to the vital structures within the prostate. So when you multiply these out, you've got a lot of information, a lot of bits of information. In fact, hundreds of thousands of data points can be used now to create sort of what you'd call an artificial intelligence model, machine learning model. So to show you how this works, and this is the software I'm going to show you. It's being demonstrated at a booth here. We do our model input, including both the MRI available information, the PSA levels, and the biopsy correlates. Put that into a developed piece of software, a black box. It's a deep neural network, and the output is what you'd call a cancer map, a heat map showing where the cancer is most likely to be, and then how it decreases going out from that. This is the estimated map. This is the treatment plan suggested by the software. We have now half a dozen people at UCLA using this clinically. It's now part of the UCLA IT. It's been FDA approved, and both radiation therapists and urologic oncologists are using this to help manage this condition. It turns out that this software was developed all at our place, but we have validated it by applying it to a group of 97 men who had radical prostatectomy at Stanford, an independent data set. And so when you plot in tumor volume here versus the predicted tumor volume from the software, the correlation is amazingly high using 97 radical prostatectomy patients, all of whom had this software applied. So it's very promising. It's very early, but we're going to hear more about this. Let me show you an example of a case. We use that software to treat a patient with HIFU last week. And again, it's all about the tract biopsy sites. Here's how we started. This is a MRI guided biopsy done using image fusion. This shows in the green, this is the MRI visible lesion. The yellow is the outline of the prostate on MRI, and the red diamonds here are the positive biopsy cores. The blues are the negative biopsy cores. Let's see. Whoops. Let me go back 1 second here. We then had the engineer extract each of these biopsy sites, which is the way we've been doing it before, to create a treatment plan, a map of where the operator would treat using HIFU device. It took the engineer an hour to do this manually. And then we applied this software called Unfold AI. It used to be called iQuest, but because of a name dispute with another company, it's now called Unfold AI. It is being demonstrated here. And the software predicted map is about the same as what the engineer took an hour to do, but it only took about 2 or 3 mouse clicks to make this one. We then took that plan and imported it into the HIFU device and used it to perform HIFU to encompass fully not just the region of interest on MRI, but the surrounding areas as well. These red dots are the little HIFU spots. This is the upper zone of treatment, and we treated this patient effectively just last week using this. So again, it's interesting how this has all evolved. It's continuing to evolve. It will grow and change. But I thought it was interesting to look up some of the press that Bernie Fisher got when he proposed focal therapy for breast cancer. His colleagues rewarded him by saying lumpectomy is murder. It's equal to malpractice. This was in the 70s. But in the 90s, by 20 years later, it's very interesting. This is a story of a New York fashion model who had a radical mastectomy for her breast cancer. She, of course, lost her career. She couldn't work anymore. And she sued her surgeon for failure to discuss a lumpectomy with her. And the judge awarded her millions on the basis that there was just no discussion of any other treatment. And that is our challenge today in dealing with people. It's not for everybody, our focal therapy, but it's something that people are going to come to you knowing about. Thank you again for the chance to show this. Neil, congratulations on putting on a great meeting.